Welcome to the woolly world of liver disease, where billy goats are bilirubin and choledocholithiasis is a swift kick to the ribs. We're starting with the big picture, a DDX of abnormal liver labs. First, we'll introduce the cast of characters, the individual lab tests. Then, we'll organize lab abnormalities into three separate patterns: isolated hyperbilirubinemia, hepatocellular, and cholestasis, covering the differential for each. Let the fun begin. The standard panel of liver tests is sometimes referred to as LFTs, or liver function tests. This is a bit of a misnomer because many are markers of liver injury, not liver function. How do you know who's who? We're getting to that. Aspartate aminotransferase, or AST, and alanine aminotransferase, or ALT, are markers of liver injury. In particular, hepatocellular injury. Hence the name, Pat and Sal's. Both AST and ALT are intracellular enzymes, normally contained within hepatocytes. But when hepatocytes are damaged, they leak into the serum. At Sketchy, elevated malt glasses are our recurring symbol for elevated ALT, while that perpetual toast represents elevated AST. There's considerable debate about the optimal upper limit of normal for ALT and AST. According to the guidelines, a normal ALT is below 25 in females and 33 in males, lower than the upper limits used by many laboratories. Alkaline phosphatase, represented by this chalk bucket and chalkboard, is another important marker of liver injury. This enzyme is found in hepatocytes along the bile duct membrane. In particular, it becomes elevated in response to bile duct stasis, aka cholestasis. Alk phos is also present in high concentrations in tissues outside the liver, particularly bone. As a result, an elevated serum alk phos can also be a consequence of bone disease. The hepatic origin of alkaline phosphatase can be confirmed by measuring the serum level of a second enzyme, gamma-glutamyl transpeptidase, or GGT, symbolized at Sketchy by a GGT gadget knife. GGT is also elevated by cholestasis, and levels usually correlate with those of hepatic alkaline phosphatase. GGT is not elevated in bone disease. That covers the major markers of liver injury and cholestasis. Let's move on to liver function, which is assessed by looking at markers of synthetic function. The liver is responsible for synthesis of most serum proteins, including albumin and coagulation factors. Impaired synthetic function is represented here by this gnarly dysfunctional liver shrub. Yep, just not synthesizing like it used to. Two readily available lab tests are used as markers of synthetic function. The first, serum albumin. Impaired synthesis presents with hypoalbuminemia, represented by these following album pages. The second marker of synthetic function is the prothrombin time, or as this announcer seems to prefer, the INR, symbolized by that intercom radio thingy. These tests reflect the activity of the extrinsic coagulation pathway. And conveniently, all of the factors in this cascade, 1, 2, 5, 7, 9, and 10, are synthesized in the liver. Impaired production leads to a prolonged prothrombin time and an elevated INR. We've saved the best test for last, bilirubin. At Sketchy, when you see billy goats, think bilirubin, of course. Bilirubin is derived from metabolism of heme, as illustrated by the stack of old heme hubcaps. In a healthy person, breakdown of old red blood cells leads to a small amount of unconjugated bili in the serum. Unconjugated bilirubin travels in the bloodstream tightly bound to albumin in order to increase its solubility. The hepatocyte converts unconjugated bili into the more water-soluble conjugated form. And finally, conjugated bilirubin is excreted into the bile ducts. The standard liver panel includes only the total serum bilirubin, the sum of both the unconjugated and conjugated forms. The total is normally less than 1. The lab can also measure the direct fraction, which approximates the conjugated bilirubin. Subtract the direct from the total to get indirect, which approximates the unconjugated bilirubin. From a clinical perspective, an elevated serum bilirubin always falls into one of two categories. The first, unconjugated hyperbilirubinemia, is, well, what it sounds like. The elevation of predominantly unconjugated bilirubin, also called indirect bilirubin, represented by this uncolored billy goat. If the lab is using older methods, they may also report a small amount of direct or conjugated bilirubin, even though the patient, in reality, has unconjugated hyperbilirubinemia. This is why we've placed this direct map under the uncolored goat. Don't be fooled, though. This is a result of unconjugated bilirubin reacting with the direct reagent. Yep, just some unconjugated bili pretending like it's conjugated. As long as the direct is less than 20% of the total, you can assume that the bilirubin is predominantly unconjugated. Unconjugated hyperbilirubinemia is seen in conditions unrelated to the liver. For example, increased bilirubin production by hemolysis. But it can also be produced by liver disorders that impair bilirubin uptake or conjugation. More on that later. The second pattern is, well, conjugated hyperbilirubinemia. The serum bilirubin is never 100% conjugated, however. Instead, elevated conjugated bilirubin is always accompanied by elevated unconjugated bilirubin, which is why this conjugated collared goat is accompanied by his uncollared friend. A few reasons for this. For one, buildup of conjugated bilirubin within the hepatocyte actually leads to reversal of the glucuronidation reaction. So some of that conjugated bilirubin is converted back into the unconjugated form. In addition, intestinal bacteria also convert conjugated bilirubin back to the unconjugated form, which is then reabsorbed back into the bloodstream. So keep in mind that the term conjugated hyperbilirubinemia always refers to the elevation of both fractions. But going forward, we'll only show a collared goat to represent conjugated hyperbilirubinemia. Conjugated hyperbilirubinemia is a feature of both hepatocellular and cholestatic disease, which will be illustrated inside the liver pen and the adjacent grassy area, respectively. If you were to just look at the bilirubin pattern, these two categories of disease are pretty indistinguishable, actually. So, you know what? If your patient clearly has liver or cholestatic disease, it's often unnecessary to fractionate the bilirubin in the first place. You can just assume conjugated hyperbilirubinemia and move on. Another sign of conjugated hyperbilirubinemia is detection of bilirubin in the urine. Conjugated bilirubin is water-soluble, remember, and small enough to be filtered through the glomerulus. In contrast, unconjugated bilirubin, tightly bound to albumin, is too big to be filtered. As a result, unconjugated hyperbilirubinemia does not lead to a positive urine bilirubin, unless the patient has albuminuria from glomerular disease, of course. Bilirubin in the urine may cause it to appear darker than normal, thanks to bilirubin's yellow-orange hue. Elevated serum bilirubin, regardless of whether it's unconjugated or conjugated, manifests clinically as jaundice. Slight elevations aren't noticeable. Jaundice becomes visible only once the total serum bilirubin reaches about 2, twice the upper limit of normal. Severely jaundiced patients may have skin that appears visibly yellow. Mild jaundice can be more subtle. On physical exam, it's most notable in 2 locations. First, yellowing of the whites of the eyes. This is sometimes known as scleral icterus. Although the conjunctiva, not the sclera, is the site of bilirubin deposition. Second, look for yellow discoloration of oral mucous membranes, particularly the hard palate and under the tongue. Alright, now that we've set the stage, farm, we'll take you through 3 major patterns of lab abnormalities and the differential for each. Pat and Sal's malt shakes, anyone? The hepatocellular pattern of lab abnormalities is seen in disorders of the liver parenchyma, where hepatocyte injury is the name of the game. Here, AST and ALT are disproportionately elevated compared to the alk-phos, hence the toasting malt shakes towering over the chalk bucket. The AST and ALT can range from mildly elevated, double digits, all the way to the thousands. What? As for the alk-phos, it may be normal or mildly elevated, less than 4 times the upper limit of normal. Boring. If alk-phos is mildly elevated, serum GGT is often elevated as well, hence the handy gadget knife leaning against the chalk bucket. Remember, GGT is telling us that the alk-phos is from the liver, not bone. Hepatocellular disease can be organized based on the time course and degree of AST and ALT elevation. Marked elevations of AST and ALT, greater than 15 times the upper limit of normal, meaning hundreds or even thousands, are usually a result of acute hepatocellular injury, represented by an acutely ringing alarm clock within the liver-shaped pen. Notice those prominent toasting malt glasses aren't far away. Here, acute means less than 6 months. Most patients with acute hepatocellular disease have some type of acute hepatitis, While the underlying disorder varies, viral hepatitis, alcoholic hepatitis, drug reactions, ischemic injury, etc., we refer to these collectively as acute hepatitis, represented by a racing goat kicking up sparks and flames within the liver pen. It's inflammation time. A more severe manifestation of acute hepatocellular disease is full-on acute liver failure. A bit like this goat. Ooh, faceplant. Yep, that's a fail. Acute liver failure, by definition, requires the presence of hepatic encephalopathy and an elevated INR. Let's step back to acute hepatocellular disease in general. Back to that gnarly liver shrub. Impaired synthetic function is a sign of severe hepatocellular disease, acute or chronic. Recall that impaired synthetic function is assessed by looking for an elevated PT-INR and a decreased serum albumin. Here in the acute side of the liver pen, severe disease includes severe acute hepatitis and acute liver failure. In the acute setting, it's that change in PT-INR we look for first. That's because it becomes abnormal quickly. Clotting factors in the extrinsic pathway, particularly factor VII, have a relatively short half-life. As a result, just 24 hours of impaired protein synthesis will prolong the PT and raise the INR. Hence the sun logo. That's one sun for one day. When INR is elevated from impaired synthetic function, administration of vitamin K does not correct the abnormality. Think of it this way. No matter how much vitamin K you throw at it, a failed liver is a failed liver. This is in contrast to an elevated INR resulting from vitamin K deficiency, which will correct with vitamin K. We'll reiterate this later. In contrast to clotting factors, serum albumin has a relatively long half-life, as emphasized by the month-long calendar falling from the album. Protein synthesis needs to be impaired for at least 3 weeks before serum albumin levels begin to drop. So, expect a low serum albumin if severe acute hepatocellular disease has been going on for 3 weeks or more. Remember, by definition, acute liver disease can last up to 6 months. Here in the acute side of the liver pen, elevated serum bilirubin and jaundice are common as well, and not just in severe disease. Even relatively mild acute hepatitis can cause jaundice, as depicted by the acute liver failure kid and the acute hepatitis kid, both of whom are riding yellow bilirubin goats. The goat is colored to remind you of conjugated hyperbilirubinemia, of course. Injured hepatocytes are particularly bad at excreting conjugated bilirubin into the bile ducts. So bilirubin backs up, all the way into the serum. Patients with acute hepatitis or acute liver failure are usually pretty symptomatic. In addition to jaundice, common symptoms include right upper quadrant pain and nausea or vomiting. Goat sickness much? Patients with acute liver failure will also have hepatic encephalopathy, a defining feature of acute liver failure. Hepatic encephalopathy reflects the liver's inability to adequately clear ammonia and other neurotoxins. Most patients with the condition have an elevated serum ammonia level, although measuring ammonia is not required for diagnosis. Hepatic encephalopathy presents with altered mental status, ranging from mild sleep disturbances all the way to coma. Look for a characteristic physical exam sign, asterixis, a flapping tremor of the hands when the wrists are extended. Hence these flapping bird wings over here. An emu, huh? That won't end well. Alright, as you can tell, we're just focusing on the big picture here. Only the laboratory findings and major clinical manifestations of these disorders. Check out our acute liver disease sketch for a more in-depth discussion of the underlying causes of acute hepatitis and acute liver failure. Well, if there's an acute version, you bet your jaundiced hide there's a chronic version. This time, however, notice that the malt glasses are pretty normal-sized. Chronic hepatocellular injury, represented by this chronically old grandfather clock, is associated with a mild to moderate AST and ALT elevation. That means less than 15 times the upper limit of normal, or to put more simply, double-digit numbers up to a few hundred. By chronic, we mean more than 6 months. Common causes of chronic hepatocellular disease include alcoholic liver disease, chronic viral hepatitis, particularly B and C, and non-alcoholic fatty liver disease. We'll discuss the differential and workup for these conditions in our chronic liver disease DDX video. Here, we'll focus on the big picture once again. We'll refer to the relatively early stage of these disorders collectively as